Welcome everyone to the first monthly MRCGP SCA study club. So for those that haven't met me before, brief introduction. My name is Muhibbur Rahman. I'm a portfolio GP, which means I'm a GP with multiple roles. I've got clinical roles. I'm a partner in my own practice. I work as a locum in some other practices. I cover 2 community detox units, and I've held various other clinical roles over the years. My main role now is in teaching. So I'm a consultant in medical education and the medical director of UMedica. So I help to develop and run training courses, but also advise other organizations like work with Medical Protection Society and various deaneries to help them get their trainees through membership and to guide them for GP careers. I used to be an examiner and invigilator for the GMC, and I sit on the NICE GP reference panel. Back in 2006, I was involved in piloting the CSA before it was launched, and I sat the first ever sitting of the real CSA back in 2007 and was awarded it with merit. And because I trained before the new MRCGP came in, I actually did video consultations for the old MRCGP, and we also had to video on VHS tapes for an exam called summative assessment. Okay, and if you think about the fact that SCA is recorded, although you're not sending off, but it's recorded and marked later, there's some crossover there. And our team at eMedica have trained over 77,000 delegates. Joining me in the faculty today, we have Masooda Rahman and Anna Greathead from the core eMedica team. So let's just find out a little bit about who's joined. Where are you training and where are you working? Are you ST1 coming really early? Are you ST2 about to move into ST3? Maybe you're less than full-time or out of sync. Are you ST3 and you're actually going to sit the exam soon? You're actively preparing already. Just share that in the chat. And throughout this session, use the chat as you've been doing to sort of get involved in comments and discussion. If you've got a question that you'd like myself or the faculty to help you with, please use the Q&A for that. And that's because with so many people, what you'll see is that the chat moves and then it can be difficult to keep track of. The Q&A, until someone in the team has cleared it, it will stay there and we can track that, okay? So we've got a range of, a lot of people are in ST3 and a couple of ST2, but mostly ST3. Right, good, that's good, because that's really what this session is for. It's not an introductory session about what is the SCA. We have recordings of that already on our YouTube channel. This is really a chance for you to actually get some interactive practice. So what we're going to do, the format for this is a short session. So about just over half an hour of interactive learning, and then a bit of time for questions and answers. So, do get involved. We'll do one sample SCA role play in an interactive learning format. I'll get you all to get involved via the chat. So use the chat for comments and discussion. What I will do now is I will restrict the chat now so that only the faculty can see what you say, see what you put in. And that's because if you are thinking, what would I like to ask the patient? And someone else already types that, you miss out on the learning. Okay, so this way, you can actually get the benefit of thinking, even if you don't actually have a go, or you don't actually, yours isn't the one that I ask, it will be in there and give you a chance to think about it, okay? So what we're going to do, we'll do an interactive SCA role play. I will be the doctor on your behalf, if you like. So what I'm going to do is I'm going to ask the questions to the patient, and the patient will answer them, but I will ask them exactly how you type them into the chat. So please don't put down abbreviations. Don't put down, unless that's what you want me to say to the patient, don't put down jargon that I understand as a doctor, as a GP, but that the patient wouldn't understand, because I'm going to say exactly how you type it into the chat. And then the patient will respond. And then that way we'll see where we navigate. At various points, I might pause the consultation to discuss some key learning points. I might demonstrate how a really good candidate might handle particularly the challenging aspects of this case. But I'd like you all to have a think about what might be going on, what might you want to ask, what might be the diagnosis, how might you manage it, okay? So that you can benefit from the session. The more you get involved, the more you're going to get out of it. Then we'll talk about the key learning points and review the relevant guidance, learning points, management, key things in data gathering, and so on. And finally, I'll talk to you a little bit about useful resources, and if you need support for the SCA, what things we offer, and then we'll finish with a Q&A to mop up any questions that haven't already been dealt with by the team. Okay, so let's get straight into it. I'll give you, remember in the real SCA, you have up to 3 minutes to read the information before the actual consultation starts. And sometimes there'll be very little like this. Sometimes there'll be even less than this. Sometimes there can be up to 3 screens worth of information. So I'll give you a bit of time to have a look at this. And then I'll ask the patient to come in and we'll do the consultation. Okay, are we ready? So what we'll do is we'll paste this information into the chat. So it'll be available if you need it, but I'm going to stop the share now so that we can actually just focus on the patient. Okay, and that's what happens in the real exam, that once your reading time is up, this disappears. You see the patient on the screen, but if you want to access the information, there is a little button you can press so that you can access it again. So, if you want to look at it again, you'll be able to check it into the chat. Okay, so what I'm going to get the patient to come on. So remote video consultation. And once they're on, I'll then get you to start. I'll just do the introduction. And then after that, I'm going to ask questions exactly as you ask them by typing it into the chat. Okay, so let me just get the patient to join us. Great. So let's begin. Hi, is that Amy Hall?
Yeah, that's me, yeah.
Hi, my name's Dr. Rahman. I'm one of the GPs here. How can I help?
I just can't cope anymore. Sorry.
Okay, remember, I'm waiting for you. Okay. Well, I'm sorry to hear that. Could you tell me a bit more about what you mean by that?
Well, it's just everything. I was just the cancer. I don't know what's wrong with me.
Oh, you seem very distressed. Would you perhaps tell me a little bit more about what's going on?
Well, I had the cancer, and the doctors, the cancer doctors, they keep telling me how lucky I am, but I don't think I'm lucky. I'm 43 and I get cancer like that.
Is it all a bit overwhelming for you?
Yeah, really overwhelming.
And how long have you been feeling like this?
Well, I guess when I got diagnosed, it was all a bit of a blur. But 3 months ago, I had my last chemotherapy, and I thought I'd feel better then. I'd be back to normal, but I'm just not.
Mm. I can imagine it's very hard. Could you tell me a bit more so I can try to help?
Well, I don't know what to say really. I expected that once the treatment was over, I'd feel like my normal self again, and I could get on with life. But I feel stuck.
I mean, I can sense that you're worried. What's on your mind?
Well, to be honest, I'm just not the person I was before. I'm worried that my he's been brilliant, but I'm worried that he's gonna have had enough after a while. There's only so much. I'm not the woman he married.
I understand it seems hard. How's your mood?
Just I just really flat. I just can't. I just do not. I thought I'd feel happy and elated at having beaten it, but I don't.
And just going back a little bit, when were you diagnosed, Amy?
I think I found the lump about a year ago. Maybe it was about 10 months when I got the firm diagnosis.
And how have you been coping since the treatment?
I think the treatment, as I say, it's all a bit of a blur. It was all very quick once I was in the system, but I've not seen the oncologist for 3 months now. I don't know when I'm going to see him again. Which I think is probably good news. It probably means they don't think they need to see me. but I don't feel like myself.
Mm. Okay, I mean, it's a lot to go through, and we're here to help you. Is there
Thank you.
anything that you're worried about?
As I say, I'm worried about my husband having had enough. And I want to get on with my life.
Mm. And how are you hoping that I could help you today?
Well, I mean, I don't know if this is, I know there are tablets that you can give for people who are feeling down. And I don't know if that's something I can have that might help me get back on an even keel.
Okay, and I mean, what do you think might be going on when you say about tablets?
Well, I assume this is some kind of depression, um, or it might be just a side effect of the cancer treatment. I don't know, but I am just feeling I would like to get my life back, and I don't know how to do that.
Okay. And do you have a good support network around you? You mentioned your husband. Is there anyone else?
Well, he's been brilliant, but to be honest, the whole time I was having treatment, I didn't see any of my friends because I was worried about catching things. I was told I had to be careful.
Mm.
My parents live in France. My brothers are busy with their families. So really, it's just Brian.
Mm. Okay. And how are you coping with things like sleep?
It's weird. I'm tired all the time and I can't sleep. I don't understand it. I struggle to go to sleep. I wake up
Mm.
early. I wake up in the night.
And are you still having any sort of physical symptoms that might be contributing to how you're feeling?
What you mean, like the cancer things?
Yeah.
Um, I think the wound from my surgery is better. I still have like aches and pains sometimes, but not anything like when I was going through the chemo. And I think I'm all right there.
Mm. Okay. And you mentioned your husband.
Mhm.
Is that your main concern, or is there anything else that's sort of more worrying for you? Mhm.
I can't cope with the thought of living like this. I'm not living, I'm just existing. I can't cope with that. And I am worried about Brian. You know, we had a
Mhm.
really good marriage, and I feel like I've ruined it by being sick.
Would you say that you're feeling low or hopeless?
Yeah, very much so.
Mm. And how does your mood affect your sort of daily life? You're struggling with sort of day-to-day things.
Well, I don't really do anything. I struggle to sleep, and then I don't have much appetite. I don't eat much. I don't really do anything anymore.
Right. Are you in any pain?
Not not really.
Okay. And are you working at the moment? Are you at
No, no.
work?
I stopped work when I got cancer, and
Mm.
they basically say I can take as long as I need until I feel ready, and I'd like to feel ready to go back.
Okay. And you mentioned about, you're worried that your husband, um, is there any reason why, like anything specific that makes you worry
Well,
about that part of things?
I'm just not the woman he married. I've lost a breast. I've gained a lot of weight with not being able to go to the gym, and I think some of the medications, and I'm just no fun anymore.
Do you think it's impacting your relationship?
I mean, he's been brilliant, but it's been a year now,
Mm.
and I'm just worried that sooner or later he's going to get fed up.
Okay. And have you spoken to your husband about these thoughts, these feelings?
Yeah, he keeps reassuring me. He keeps telling me not to be silly.
Mm.
um, but it's not just that. It's just I want my life back. I thought I'd feel happy and elated, and I don't.
Okay. And you mentioned about tablets, and
Mhm.
definitely we can talk about tablets. that sometimes people with low mood, they can have thoughts of things like self-harm or suicide. Is that something that has ever happened?
I have on occasion thought it might have been better if the cancer had done its job, but I don't think I could ever or would ever do anything to hurt myself like that. I couldn't do that to Brian.
Glad to hear that you've said that. Um, and is there anything that you've tried so far or in the past, that might have helped?
What with feeling low,
Mhm.
I mean, before I was ill, if I felt low, I'd, have a glass of wine, or I'd go out to the cinema or meet friends, or, um, eat a bar of chocolate. But I don't do any of those things anymore.
Mm, okay. And you mentioned that maybe it could be side effects. Are there any, apart from mood, are there any other things that have been happening that are new that you think maybe it could be to do with the treatment?
Um, it's difficult to know what it's like. I sometimes feel a bit sick and I don't have much appetite, but I struggle to sleep. But I don't know if that's just, I don't know what it's all part of, but
Mm,
I
okay.
feel fine. I'm taking tamoxifen. I
Mm.
think that's fine. I don't think that's a problem.
And
I know
did
it's
the
important I take it.
yeah, and did the team sort of refer you or put you in touch with other forms of support, like Macmillan, for example?
No, I think that was offered, but um, we didn't take that up.
Mm, okay. And can I ask, you mentioned your husband. Are there any children in the house?
No, no, we don't have children.
Mm, okay. Um, and would it be right to say that you've perhaps been overwhelmed with the current situation and everything that's been happening?
I think that was the case when the treatment was ongoing.
Mm,
Um, I don't know why I'd be overwhelmed now, because now I'm just taking a tablet a day, and I think, apart from the fact that I feel so flat,
mm.
there's no reason for me not to get on with my life now. I just can't seem to do it.
And how do you see your future?
I think that's why I'm having this appointment, because unless something happens to change it, it's just going to be this for another 40 years.
Mm, okay. And you mentioned that you'd put on some weight, you used to go
Mm.
to the gym. Are you able to start doing some physical activity now that your treatment is, sort of the main part of your treatment's done?
I guess on paper I could,
Mm,
but I used to be really motivated to do it. I used to love going, and now the thought of it, I,
mm.
yeah.
Okay. Okay, I'm going to pause it there. Okay, thank you very much, Amy. I'm going to come back to you in a minute. Okay. So a couple of you have, few people have said similar things that maybe they'd want to ask some specific questions. So let's do that together. What are some of the specific things that you'd like to ask this patient to help you maybe, assess a little bit about what's been going on from what we've already been mentioned? Think about some specific things that we want to get more details on. Okay, so um, their mood, we found out a little bit about that. We found out about sleep, confusion, appetite, anhedonia. So do they enjoy things that they would normally enjoy? Any symptoms of anxiety, finances, the impact cosmetically, the fact that they've had a mastectomy, smoking and alcohol intake, someone's mentioned, recreational drugs, any sort of psychotic symptoms, if they've thought of anything else besides medication, concentration. Okay, good. So there's a lot of things. What I'm going to do is I'm going to share my screen and just talk a little bit about some of the things that would be important. And I might show you how we might actually tackle some of these, and then we'll continue to think about the next steps. Okay. So, from what we've heard so far, it sounds like her mood is being impacted. So if you get a suspicion that someone might have depression, then it's important that we sort of take a focus history, right? We want to look at the mental state. We want to look at low mood. And, she mentioned that she felt a bit down. We asked about feelings of hopelessness or helplessness. Okay. And then some of the other things, specifically anhedonia. Do they enjoy the things they used to normally enjoy? How are they sleeping? What can be the changes in sleep if someone's depressed? Type into the chat. How can sleep be impacted by depression? Can everyone see my screen, by the way? Yeah. Good. Okay. So yeah, sometimes people will struggle to sleep when they're depressed because often they're having lots of negative thoughts. It keeps them up. They can't turn it off. Sometimes they just got no motivation and they spend long periods sleeping or in bed, even if they're not sleeping. And so it can impact it both ways, right? It can lead to broken sleep or poor sleep or altered sleep patterns, or it can lead to excessive sleep. Yeah. Okay. So getting the details is really important, right? Similarly, what can happen to appetite? If someone's feeling depressed, what are the ways that appetite can be impacted? So sometimes people have no appetite. They don't enjoy the taste of things. They don't enjoy cooking, so the anhedonia can mix in with the fact that often everything tastes a bit bland. That can sometimes go the other way, right? Sometimes someone's feeling really down. Maybe there's been a relationship breakdown, and then they're feeling thoughts of hopelessness, helplessness. What happens? You get the big tub of ice cream and a big spoon, and you put the sad songs on, time after time, and you eat a whole tub of ice cream, right? Okay. And so it can be impacted both ways, can't it? Okay. Energy levels. One of the core features of depression is that people often feel fatigued, low in energy, tired, don't have the energy to do things, even if they wanted to. And then often they don't have the motivation that links in with feelings of helplessness, anhedonia. So can you see, getting the detail of that? So you want to be focused. Specifically though, early on, if you're not sure, could this be depression? Is it worth taking a full history of that? What does NICE recommend? It recommends that early on, if you suspect that there might be some low mood, that you ask the core depression identification questions. Sometimes this is described as PHQ2 because it's actually linked to the first two questions in PHQ9. So during the last month, have you often been bothered by feeling down, depressed, or hopeless? During the last month, have you often been bothered by having little interest or pleasure in doing things? And if they answer yes to either one of those, you want to take a full depression history, a more detailed screen. Okay. So once we've done that, we think about this particular patient. What are some of the other things that are really important? Well, we identify some of them, right? We want to find out about their support network. We found out about the partner at home, that they've not been working since their diagnosis. Have they got any protective factors? So actually the fact that they've got someone at home, whereas someone that's isolated is higher risk for things like suicide. What treatment is she on? So she had the chemo, she had a mastectomy, she's had hormonal therapy, she's on tamoxifen. Is she taking it regularly? Are there any side effects? I'll come back to some of the side effects a bit later on. So what do you think the diagnosis is from what we found so far? Yeah, this patient fits to have clinical depression, right? And one of the things that's really important here is about managing risk. And so a really sensitive but really important question is to ask about thoughts of self-harm, suicide. Have they ever attempted it? Would they do it? Is there something stopping them doing? And she mentioned she would never do that to Brian. That's a protective factor, right? So this is one of the bits where I think it'd be useful to sort of have a little bit of a go at it. So can I have a volunteer? If you use the raise hand feature, if you'd like to have a go, and then I'll promote you to a panelist, which will allow you to turn on your video. So if anybody would like to have a go, we're going to just have a go at this part of, we've established that they've got some of those features that fit with depression and want to look at if they've had thoughts of self-harm, suicide, and so on. Okay, so there we are. someone's Dr. Burley, is it, has put their hand up first. Is it Gurija? I think it is. Apologies if I've said that incorrectly. You'll see a little pop-up say that you've been requested to become a panelist. If you can just accept that, and then that will allow you to turn your video on. Now, you've established that, you think that she might have depression, and we're now just going to have a go at that bit of assessing that really important question.
Ami, I understand that it's quite a lot for you. And sometimes with the similar kind of experiences people undergoing, they sometimes think of harming themselves or ending life. Has it any time happened to you? Do you think about those things?
I sometimes think it would have been better had I died with the cancer, but I wouldn't do anything to hurt myself. I couldn't do that to Brian.
Yeah, I'm so sorry to hear about that, but I'm really glad that you're thinking about Brian. So mm, um, you mentioned me that it's quite a lot to go through with this coping, and do you think that in any way I could help you?
I mean, if there is some way that you can help me not feel so flat and so down.
Great. Thank you very
Yeah,
much.
I totally agree.
Thank you very much, everybody. That was very good. Thank you. So great. Okay, so it can be challenging, right? And one of the things is that sometimes it's not just what we say, but the way that we say it, right? Because it's a sensitive question. It might be, even though they're feeling down, it might come to them as a bit of a shock, right? It can be unexpected. So one of the things that we can do is we can use the technique of signposting. Okay, so let me demonstrate how we might do that, where we can add in the signposting. And I'm going to show you something that you want to avoid. Because what you don't want to do is you don't want to just drop it in at your normal pace of speaking. Sometimes it's not just the words that we say, but how we say it. It's about body language. It's about tone of voice, pace. For example, if you just drop it in at the same pace as you're asking other things without any pause, without any warning, sometimes it might not come across as sensitive. Let me show you. Let me show you what you don't want to do. Okay. So Amy, I mean, it sounds like this has really impacted your mood, your energy levels. It's got to the point that, you're concerned about your appearance. You're worried that your husband, might lose interest in you. You're not working. You're not enjoying the things that you normally enjoy. Your sleep's affected. Everything's just getting you down.
Yeah.
Have you thought about killing yourself? Can you see, if you just drop it in as if it's almost like a suggestion, can you see how insensitive that would be just to say it like that without any warning and at the same pace and at the end of a sentence, as if it's part of all of those other things? I've just summarized all the things that are going on that are making her feel down. And then, you don't want to do it like that, do you? Whereas a much better approach would be something like this. So, Amy, I can see that this has really had a big impact on your, not just your mood, but your day-to-day activities. You mentioned that you don't have the motivation to go to the gym, impacting your relationship. And I'm going to ask a really important question now. That it's very sensitive, but the reason we ask it is that we want to make sure that we're doing everything we can to support you, and that we're doing whatever we can to keep you safe.
Okay.
So sometimes when people are feeling the way you've described, they can have really dark thoughts, like harming themselves or even killing themselves. Has anything like that ever crossed your mind?
No, I've sometimes wondered would it be better if the cancer had done its job, but I couldn't ever do anything to hurt myself like that. I wouldn't do that to Brian.
I'm so glad to hear you say that, and you've got a strong reason, why you wouldn't do it. That's really, really powerful. I just want to say that if things change and you find that your mood is getting worse, or you do have a dark moment and you think those thoughts and they sort of become persistent, are you thinking about it more regularly, please contact us. We're here to help you. We're here to support you. There's lots of things that we can do to offer support.
Thank you.
So can you see how by using that technique of signposting, you let them know that something a bit unexpected might be coming, and why you don't. But can you see I change my tone? I'm leaning in a little bit, even though it's wrong. Rather than just dropping it in at the same pace without any pause. Okay. Good. So let's talk a little bit now about the management side of things. Okay. So what are the options? We've established that this patient has got, a significant level of low mood symptoms that it fits with clinical depression. So what are the options for management for this patient as a whole? Okay, so suggestions are CBT, SSRIs. Okay, so okay, let's talk about that in a bit more detail then. All right, so and what else? So far we've given community support, people have said, follow-up and safety netting. We'll come on to that. Macmillan, great. Okay, great. So, things to think about. Remember, you don't want to just treat the condition. You want to treat the person. I.e., this patient, yes, it looks like they've got depression. We've got to look more broadly beyond the depression. We want to help them with that. We also want to think about them more broadly in all of their needs, physical, psychological, social. So think about things like, Macmillan. It was mentioned, but they hadn't taken it up. They might benefit from that. The oncology team, they might have a cancer nurse specialist. We could maybe find out when are they following up. Like she said, the fact they've not asked her to go back, that can often be a good thing. But if she was only diagnosed a year ago, even if they've done the operation and she's had various other forms of treatment, they'd often follow up at least for a couple of years before they totally discharge. So it might be just she's not aware when the next appointment is. And sometimes then people can feel a bit abandoned. Okay. And then local mental health resources. So they might benefit from some talking therapies. But we also might think about, could we start a treatment in primary care? There's nothing to suggest that she needs an admission, is there? She's not actively suicidal. So we could offer, alongside these things, we could offer an antidepressant. And she specifically mentioned if there was a tablet that can help her with her mood, right? Okay, good. So what would be an appropriate treatment? So someone said that we can't give SSRIs. Anyone think anything different? Someone's mentioned maybe doing PHQ-9 to monitor symptoms in the future. Okay. Other people have mentioned maybe some alternatives. Great. So let's talk about that. So an appropriate SSRI will be first line. There are two that you should not use because she's on tamoxifen, and they're fluoxetine and paroxetine. Anyone know why that is? What do they do? Why is it that they're not recommended with tamoxifen? What is the interaction? So both fluoxetine and paroxetine, they decrease the efficacy of tamoxifen. So it's not that they won't work as antidepressants. They may well help with the mood, but it's just that they may interfere with the work of the tamoxifen and therefore increase her risk of recurrence. Okay. You can use SSRIs, but just not those two. So, useful options you could consider would be things like citalopram or sertraline. What wouldn't be recommended as a first line would be other classes like SNRIs, for example, things like duloxetine. Those are second line, right? And a follow-up, generally, if you start someone on an antidepressant, you would normally follow them up about 4 weeks' time because you want to allow enough time to let it work. But given she mentioned that she has had suicidal thoughts, even though she's got a protective factor, she wouldn't do it. And she's got a lot more going on as well. Personally, a patient like this, I might offer to see them maybe in a couple of weeks just to see how they're getting on, maybe even a telephone consult just to check in on them. And then I'd still see them at 4 weeks to see how are they getting on. And this is where what someone mentioned is a really good option. That I had a patient like this actually last week, young patient. Throughout the history, it looked like they've, got depression. So, at the end of the consultation, I went through PHQ-9 and got a score. And then I said, when we see you in 4 weeks, I started them on an SSRI. We'll do this again. Why? Because that's a useful way to see, has it kicked in? You also can check in if they've had any side effects. If they haven't, and there's no improvement, one of the things is, if you started on a low dose, like citalopram 20, you might consider increasing, or you might give it a couple more months. So that can be quite useful, right? And we'll talk about what things that we could use for that in a minute. And then safety netting. So part of the safety netting, I've sort of covered that, if they have some of those thoughts, self-harm, suicide, that, we want them to get help as soon as possible. what other things might be important? Anyone think about the side effects or serious warnings, if you like, of being on tamoxifen? Great. So someone said endometrial cancer. Someone else has mentioned VTE. Okay, well done. So if you look at the product characteristics for tamoxifen, there are sort of predominantly 3 serious warnings that the manufacturers themselves mention. That they come from one of the major studies that looked into this in women with breast cancer. So one of them is uterine malignancy. So you warn them that, and it'd be important to ask that, are they still having periods? If they are they changed? This patient was still young. She's premenopausal. Okay. Now, sometimes things like chemo, some of the other treatments that they've had, they can have an impact on that. But that would be a really important question, that if they get erratic bleeding, they get new bleeding, they get a change in their cycle, that they need to come and let us know. And then the others are increased risks related to tamoxifen. So stroke, and then thromboembolism, pulmonary embolism, DVT. So again, if they get any slurred speech, weakness, if they get a swelling or pain in the calf, if they notice that they're coughing up anything that's pink or red, if they get short of breath suddenly, for example, those are serious things just to be aware of in relation to tamoxifen. And then in terms of what could we use to, get some kind of score, how severe is their depression? We've diagnosed them. You diagnose them through history. You're looking for the ICD or DSM criteria for clinical depression. But then to put a severity to it, there's 3 tools that are validated for GP use. PHQ-9, it's got 9 questions. Maximum score is 27. Minimum score is 0. You've got HADS, which have got 14 questions. Sometimes people get put off by the fact that the first word in HADS is hospital. Although it was developed for use in hospital, the Hospital Anxiety and Depression Scale, HADS, is validated for GP. It covers both depression and anxiety. 7 of the 14 questions are about depression. 7 of them are about anxiety. And then the one that no one really uses in GP, just because it takes a long time, but it's used a lot in hospital psychiatry, but it's validated for GP, and that's the Beck Depression Inventory 2nd edition. That's got 21 questions. That's why often there isn't time. PHQ-9, I was able to do at the end of that recent consultation. It took about 2 minutes to go through it. It doesn't take long. Okay. So, you might mention doing some kind of a questionnaire so that we can repeat it when we see you in 4 weeks and see how you get on. Okay. So then if we move on to relating to others, showing empathy appropriately. Let me show you something that you want to avoid. Can I get Amy back? Okay. Imagine that she has just told me about, if you go from the bit about your body image, Amy, and how that's made you feel about yourself and about your husband, and then I'm just going to demonstrate what would be an inappropriate or insensitive thing to say, such that it could get you marked down, but also might upset the patient.
The thing is, I'm not the woman he married. I've lost a breast. I've gained lots of weight because of the treatment and me not being able to go to the gym. And I just feel like he's going to lose interest in me because I'm just not the same person.
I completely understand, Amy. Now, do you see, for me as a male doctor, to say to a patient who's had a mastectomy, I completely understand. This is an example of false empathy. Someone might think, oh, I'm using the right words. I'm saying but how do you think the patient might feel? How could you understand what it's like? You haven't lost a breast. And even if I had to have one of my pectoral muscles removed, as a male patient, it's different to a female patient. Okay. Do you see, even if I had the same thing, everyone's situation is different. So something like that can come across as insincere, and sometimes it can make them really upset. They might actually get angry. How can you possibly say that? How dare you? So rather than that, what might be more appropriate is some of the things that you guys shared in the chat. You can say what you see. I can see this is really difficult for you. I can see this is really important to you, your relationship, and it's upsetting you. Even though you said your husband's supportive, the fact that it's worrying you is having an impact on your life day to day. I'm sorry to see that. You can see that's different to, I completely understand. Okay. And then active listening, even right at the beginning, what was the opening line? What did Amy say right at the beginning? She said, I can't cope. Now, that can mean different things to different people. So sometimes just reflecting that back, especially early on, that can be really powerful. Let me show you again. How can I help today, Amy?
I just can't cope anymore.
Oh, I'm sorry to hear that. And when you say you can't cope anymore, could you tell me a bit more what you mean by that?
Since the cancer, I can't cope with living like this. I thought I'd be back to my normal life, and I'm just not anywhere near.
Thanks very much, Amy. We'll leave it there, and I'm going to share the screen again, and we will continue. Okay, right. So things like body language, position your camera in such a way that when you're looking at the patient, it looks like you're looking at them. Because if you have it, let's say my camera was over there and they're saying something, they're really upset, and I'm looking there, what does it look like? It look like I'm not interested, right? Okay. So things like that, small things that can make a difference. Position it beforehand, record a couple, watch it back. And then, as I demonstrated, it's signposting before you ask certain sensitive questions. Okay. For example, something, because she mentioned that she's worried about her husband a few times. What's another sensitive but perhaps important question that's an important part of people's lives that you might ask about? You might ask about sexual health. Again, you might signpost something like that. I'm going to ask a sensitive question, but you've mentioned a couple of times you're worried your husband might lose interest. Can I ask, are you still having a physical relationship? Are you still having intimacy between yourself? And you might explore that a little bit, but signpost it before you just ask it. Do you see what I mean? Okay. Right, good. So really, that's the end of that role play, if you like. I just want to talk to you a little bit about some of the support that we can offer if you'd like to access some of our resources or courses. And then I'll take questions and I'll do my summary so that we can be finished, because I can see we've run over a little bit. So that case was adapted from one of the 75 practice cases in our recently published MRCGP SCA casebook. It's the first casebook with mark schemes that are specific to SCA, because in SCA, diagnosis is in the same marking domain as data gathering. So it's data gathering and diagnosis. And then clinical management and complexity is weighted 50% extra compared to the other domains. And then it's relating to others rather than just interpersonal skills, which is a bit more broad. And so there's 75 cases. For each one, the slides that I went through in relation to things like this, things like the treatment options, these are actually adapted from the mark scheme that's in the book for this particular case. Okay, so for each case, there's like a sheet for the patient, usually a couple of pages with detailed scripts. How should they behave? What should be their opening line? What things to give out? What ideas, concerns, and expectations to bring in if asked about it. Detailed background, what symptoms are they having, and so on. There's a doctor's sheet similar to the format you'll have in the exam. And then there's a detailed mark scheme with the domains broken down, but then also key learning points for discussion and links for further reading. So it's 400 pages. It's a big book, 400 pages A4, okay? And so, there's an introductory section with some tips on how to approach SCA, but the bulk of it is 75 cases, including a full mock exam with 12 cases that touch on all of the 12 SCA blueprint domains, okay? So that's available from our website. The cases that are in there are also available online in our online SCA case bank. That also has some videos giving examples of good practice, a couple of consultations, and some other tips. At the moment on the SCA case online, there's slightly fewer cases because it doesn't have a full mock like the book has, 69, but that will be harmonized over the next couple of months. And then we've got a GP 100 case crammer. So how, we've sort of talked through some of the key learning points in terms of data gathering, diagnostic criteria, red flags, management, interpersonal skills. We've done that for 100 case scenarios that you might see in everyday GP, in an exam setting. It's 8.5 hours, just over, of videos. And for each of those 100 cases, I discussed the data gathering, what are the key things to cover, how to take a focused history, what are the key risks, red flags, not to miss, examination, because it's not just for the exam, it's also for everyday consulting. So I demonstrate some of the examinations, current guidelines for management. So it's been updated this year. but also things like, interpersonal, how to explain things in clear, concise, confident language. And every fifth case, so it's a blocks of 5 cases, the videos, every fifth one is an interactive case with a simulator. And you'll see the audience is asking them questions, and you can sort of think along what you'd like. And it comes with a 362-page PDF course booklet, which has the teaching slides covered in those 8.5 hours of videos. Okay. These are some of the cases covered. And then if you want sort of to practice and see lots of role plays with professional simulators, we run a full day interactive SCA course. So the next one's on the 20th of November. At each course, there'll be 4 members of the faculty. So there'll be myself, either Anna or Masuda, to give feedback, to deal with questions. We have a professional male simulator, professional female simulator, and then we take a maximum of 12 doctors. So it's a very small group. What that means is that everyone can get detailed individual feedback. Everyone will do at least 1 full mock, and will get also involved in some of the interactive cases. You'll get very detailed individual feedback. What do you need to work on personally? Okay, so that's our SCA interactive course, and we have various bundles that include, some of these things together at a discounted rate. So you'll find all of these things, if I just show you, on the eMedica website. If you go to eMedica, there's a whole section for MRCGP SCA. If you click into that section, you can see, there's the SCA course. So the next one is the 20th of November. We've got 6 spaces left for that one. After that, we'll have one on the 9th of January. We haven't got one in December because we've got a lot of other things on, and then, different members of the team are off. But we've also got, things like the GP 100 case grammar. We do one-to-one coaching, the cases. In the book section, go back here, you can see the SCA casebook is available there. Okay, so that's things that are available out there if you'd like support, with your SCA preparation. So if anyone's got any questions, please ask them in the Q&A rather than the chat. I'm just going to do a summary for those that haven't got anything to ask in the Q&A. And just to say that, look, in every SCA case, all 3 domains are going to be assessed: data gathering and diagnosis, management and complexity, and relating to others. The management domain is weighted 50% extra compared to the other 2 domains. But in order to have time to do the management effectively, you need to really focus on your data gathering. Ideally, you want to wrap up the bulk of your data gathering in the first half of the consultation in about 6 minutes, so that by the time you explain diagnosis and discuss it, remember that's part of the data gathering and diagnosis domain, you'll have enough time to go through your management, including things like follow-up and safety net. Okay, because the most common reason to lose marks is actually to do with management, especially because it's weighted 50% more. Okay. And often that's not because the doctor doesn't know the management, it's that they just don't have time to do it. Because when the 12 minutes is up, it just stops just like that. And then the next patient's details flash up. You can't ask for even 10 seconds extra, okay? Never mind, I needed 1 or 2 minutes to finish this off or discuss, when I'd like to see you again. And relating to others, the interpersonal skills, that's assessed throughout the whole consultation. Ultimately, consulting well is a skill. Once you've got your, sort of comfortable in your own consultation style, after that, if you consolidate your knowledge and you know your stuff, then the more you practice, the more comfortable you'll be, and you can treat it like a normal clinic. And ultimately, like anything in life, prepare and you will succeed.